topics as always, and we'll go from there. Welcome everyone. We have a good crowd today. We have some new folks who've come to the Arkansas APCD Data Users Group session. For you, we hold these quarterly and we take feedback from our data users, largely from the survey that we will administer after this call, and for working with you throughout the quarter to pick the subjects that we focus on. So our slide monitor today is Michael Farrell. Michael, if you wouldn't mind advancing to the next slide. There we go. All right, so again, welcome. The topics we are going to cover include, you can see here, continuous enrollment methodologies, COVID-19 analytics, and the latest APCD release information and data tips. As I said a moment ago, we choose our agenda based on feedback from our users. The Arkansas Center for Health Improvement, that the entity that administers the Arkansas APCD, is a big user of our data, and they will be featured in the first two bullets here. I should note with some pride that this is our fourth data users group of 2020, like I said, quarterly, but we're picking up steam. We had at least 3 last year, and as we move forward, they will, I don't know that we'll have them more frequently, but certainly they will get more and more robust. There's a slight change in the topics we're going to cover. In the invite, we included a topic called county level population. And it just wasn't baked enough to show today. But what we are doing, I'll talk about at the highest level, is utilizing the Arkansas APCD data to build reasonable point in time population estimates of the Arkansas counties. And it's kind of hard because we have by definition, the Arkansas APCD does not include all insurance claims, just the fully insured. It doesn't include uninsured. And our Medicare data, which represents the older population, of course, is always a year behind because that CMS takes longer to prepare their data. But hopefully when we have our next data users group, we will have some results and some methodologies that you could possibly use when you are doing your analytics. So Michael, if you wouldn't mind, let's continue to the next slide. I am Kenley Money. I'm the Director of Information Systems Architecture here at ACHI. I'm the APCD Director. My team spends the multitudes of hours to wrangle all the submitting entities into providing their data to give you the data that you can consume. Our next two speakers today, Nicole Sanders and Mike Motley, they are on the Arkansas Center for Health Improvement's analytic team. They'll do some additional intro. And if you've been here before, you know them well. They have extensive experience in using the Arkansas APCD and are a great resource for us as we answer our own questions and address any we get from you. So without any further ado, let's go to the next slide. Oh, I forgot, I have to make an introduction here. So when the Arkansas APCD began back in 2015, it was a mandate, Act 1233 of 2015, which established the Arkansas Healthcare Transparency Initiative. Now, the APCD is the primary tool for the Healthcare Transparency Initiative. It is the engine that runs the car, if you will. So we built it first and we branded it first. And it is and it will continue to be the chief source of data for information for Arkansas. But we are moving our branding to focus on the entity stated in the mandate, the Arkansas Healthcare Transparency Initiative. Arkansas APCD is going to still be there, but we are moving, we're redesigning our website, we're redesigning all of our communications to feature the Healthcare Transparency Initiative. And the APCD, all the work we're doing is evolving to feature the information that is mined from the APCD data. So you see the new logo on the right, and you'll begin to see that logo more and more. In fact, if you've been on one of our calls before, you'll notice that the PowerPoint template is a little different, and the new logo has been added to the bottom. So I wanted to make this introduction here so you will not be surprised in the future when you see APCD evolve into the HTI, the Healthcare Transparency Initiative. All right, Michael, let's go to the next slide. So I'm going to introduce Dr. Nicole Sanders, and she is going to talk about continuous enrollment methodologies. This is a question that we have gotten not only on our survey, but in lots of the technical support that we have provided data requesters about how to wrangle enrollment data to understand continuous enrollment. So let's go to the next slide, Michael. Nicole, it's all you, and Michael will move the slides as you ask him to. As Nicole wrangles her microphone. Are you there? She's there, I'm sure. Maybe. Stand by. There she is. Oh, Nicole is muted. Michael, can you unmute Nicole?
There we go.
Okay.
Sorry. Okay. It's a little persnickety about muting and unmuting. That's okay. Okay, so yes, continuous enrollment in the APCD data can be a little tricky for sure, because we have, as we've discussed before, multiple payers who have their own ways of handling their data. And we have to be able to handle all of those different ways in a efficient and consistent manner, ideally. So what I'm going to do is we'll go over the different things you need to think about when planning how you're going to calculate continuous enrollment. I'll give you guys some different examples and show you the things that I look at and to make a decision about how to proceed. And then I'll go over two possible approaches. So continuous enrollment is defined as a member having healthcare coverage from a coverage plan, a particular coverage plan or many plans over a specified period of time without a substantial break in their coverage. So what you need to consider when deciding how to handle it or choosing a methodology is, are you wanting to look at plan-specific coverage? So are you just interested in how Medicaid handles certain aspects of healthcare? Or are you interested in looking at, like, does your study population need to have been enrolled for a continuous period of time to be included in the study? I know that is important for a lot of research. Also, the length of continuous enrollment. Now, you know, that's really straightforward in theory, because, you know, usually you care about 1 year, 2 years, and it doesn't, the important part here is that you also need to consider what unit of time you're going to use to determine this. And then finally, are gaps in coverage even allowed? Because that can get really tricky, and I'll show you some examples of why. Okay, Michael. Okay, so as I mentioned, plan-specific outcomes. This is typically fairly straightforward when you have like a member participating in a single plan that came from a single submitter over whatever your period of time of interest is. For example, Medicaid coverage of certain diagnoses. what you need to consider though is that some payers, Medicaid is a fine example of this, they have an aid category, and I'll show you guys this example too, that indicates what type of plan they're on. Some plans are not full coverage, but they're still in there because they cover a variety of things. And that can affect like overlapping coverage, overlapping segments of coverage. Okay, population healthcare outcomes. So in this case, if you are interested in something like the overall, I have a favorite term for this and it just slipped my mind, but the healthcare history of a single person. And they have perhaps overlapping plans or consecutive plans across different submitters. That's going to require you to use the APCD unique ID, the hash ID. And we talked about doing that in our last data user group meeting. And one of the examples I can give you for this is when you are maybe looking at a certain provider, we actually look at help the CHCA's community health centers. We help them look at certain measures, quality measures, and we do it by tracking patients regardless of their coverage, but wherever they went and got health care. Sometimes you want to make sure that they had coverage the whole period of time and not just, you know, wherever they get their health care from or when they get it. So that's another consideration. Next slide, please. So here is a nice straightforward example. I typically look at the submitter. We have the product identifier, ME040. That will tell you, for example, if we have HIOS ID, like you can get the HIOS ID from the last 2 digits of the product identifier if it is a QHP plan. For Medicaid, the product identifier can be important, and you'll see that in an example. And then, of course, the member ID. And you can see that it just, their enrollment start dates and enrollment end dates are consecutive and nice and clean. And I don't have a pointer. That would be neat. Okay. So let's see. Let's go to the next slide. Okay, so this is an example of multiple plans and multiple submitters. And this is like what I was saying with Medicaid. This is an interesting case. So the first row, you have good old, what I call aid category 25, which is just Medicaid. But the next 2 rows, and you can see the health plan, ME164A, that helps you narrow down what each of those aid categories might be. Those 2 records actually give you an idea that this particular member went to the QHP, went and participated in QHP. During the, on the second record, you can see that they were in the, what's the word? Anyway, it's before they get assigned to an actual plan. Like before they technically are assigned to, in this case, they ended up in Celtic. And you see that there's an overlapping segment here where the second row goes from March 1st to August 31st, but the third row starts at 6/1. This happened a lot during this time period, and we were studying the QHPs and Medicaid, and it was very difficult to determine when their actual QHP started in times because their enrollment end date wasn't updated for the intermediate period, which is the second row. And I think I discussed this on our last data user group, but you have Medicaid enrollment records for QHPs, but you also have their actual enrollment record in the private payer group. Medicaid does not have any claims for this particular ID number. It's all going to be in the private payer. So that's something just to make note of. And then you can see that eventually the person went back onto Medicaid. And I want to point out that if there is an enrollment end date that is 12/31/9999, sometimes you can assume for some payers, and I can't tell you who because sometimes you just have to look, that those are still open segments, in which case you would want to replace the 12/31 perhaps with your end date of the study. So just keep that in mind too. Okay, next slide. Okay, as I said, other considerations you need to make include the length of continuous enrollment, and so months, quarters, what unit of time do you care about? Most of the time we do months of coverage, but you need to decide at what point is a unit of time flagged as a covered unit of time. So if month is the unit of time, what do you do if an individual has coverage that either ends in the middle of the month or near the end of the month? Do you include that month? Do you exclude it? I mean, that is going to be completely up to you, whatever you're the most comfortable with, or perhaps what other studies have done that you're trying to emulate. Are any gaps in coverage allowed? So for HEDIS measures, for example, you can have, I think, up to a 45-day long gap in commercial maybe, and a 30-day gap in Medicaid. I could be mixing those up, but the point is those two different types of coverage plans have different lengths of gaps that are allowed. Also, is it a 45-day long gap that's continuous, or can they have 3 gaps that add up to less than 45 days? Sometimes you just care about if they had coverage for 11 months out of 12 months. That's fairly straightforward. Okay, let's go to the next slide. So here's an example of what you would see with a coverage gap. And it's really just determining the difference for this particular example that would be between the enrollment date of the first record and the disenroll. I'm sorry, I said that backwards. I tried not to. Okay. The disenrollment date, which is ME163A of the first record, and the enrollment date of the second record. This gets tricky though when you have overlapping segments, which I will show you. Okay, let's go to the next slide. Okay, so this is a good example of a Medicaid enrollment record. I mentioned that the product identifier is what Medicaid uses as the aid category. And then the health plan, ME164A, gives you a little more explanation of what that aid category is representing, there is a lookup table that it includes the aid categories and the health plan types on Medicaid. I think we have sent that around before, but I'm sure if you let us know, or we can even send that around later. I'm not going to promise things since I'm not in charge, but I'm sure you guys can get it. But it'll tell you like when the aid category is 01, there's that one's straightforward, but for like aid category 06, which we saw was for QHP plans, there's actually multiple different types of health plans that fall under that aid category. Okay, so let's look at this example for a minute. You can see that this particular member was actually on Our Kids First for a couple of years, and then there was probably a change in something small, and Medicaid started a new enrollment record. Or there's a variety of reasons why Medicaid may have done that. But we have a new record that also that's continuous with the previous record. And it has that 1231-9999, which would indicate that this is still an open segment. And for Medicaid, that's a pretty safe assumption, unless there's another record that indicates it's not, that there was a data issue. So the third record is actually supplemental coverage that parents can opt into, and it's called TEFRA, and some of you may be aware of what it is. And this particular coverage was from May 1st, and it was about a year and a half or so. Now, this would have overlapping segments, but you would want to look and see what TEFRA really was. Maybe it matters, maybe it doesn't, but you'd be able to tell that it's supplemental, and you wouldn't have to worry about that particular record. Let's go to the next slide. So interestingly enough, let's say that this is the same person based on their hash ID. And you can see that they actually started coverage on a commercial plan. So if this is a child, it could be that their parents got coverage and no longer needed Medicaid. And the nice thing about TEFRA, though, is that it is supplemental again, and it can coincide with commercial coverage. So that's the kind of thing when you see stuff like that, go to Medicaid website, look up what those plans are. Let's go to the next slide. Okay, let's talk about possible approaches. So the simplest approach, I think, is to really just, and I'll show you guys examples of what these tables would look like. It's really just to create a table with distinct records of submitter, member ID, gender, date of birth, the hash ID, and then 2 calculated fields that represent a unit of time field and the eligibility flag. So for a unit of time, the simplest example again is, say you're looking for a month, looking at whether or not an individual was enrolled each month of the year. And you could have your unit of time field be a concatenation of the year and the month, like this example, 2018-01. That would be the first record. And the second record might be 2018-02. And then you would have your eligibility flag, which would either be a 0 or 1 to indicate if they were actively enrolled during that time. Let's look at the next slide. So here's an example of that. We have somebody that was enrolled, and the first, we'll say, unit of time in the study, they were not eligible. So their flag is 0. Now, this is where you have to decide if they were enrolled halfway through the month. Are you going to keep that as an flag that as an eligible unit of time or not? Now, the nice thing about using this method is that it's fairly straightforward coding in SAS or just in SQL, and it allows for you to be able to just sum the eligibility flags across individuals. And you can group by either member ID or you can group by the hash ID. One disadvantage is obviously the lack of precision, which I just explained. You need to decide how to handle people who were enrolled at the end of the month. They're halfway through. Okay, let's look at the next slide. A lot of people also do a similar approach, but they use a wide table, and they'll transpose the unit of time as columns, which are populated by the eligibility flag. So you see that we have 2 records of 2 different individuals, and those last 3 columns represent October 2020, November 2020, and that should be December 2020. And then we just have a 0 or 1 for when they were active during that month. So the nice thing about this particular type of table is that for at least small groups and short periods of time, you can look and see if there's a pattern in the type of coverage. It's also fairly straightforward coding, just like the long table. It's built off of the long table, really. But a disadvantage is if you are looking at more than 1 year, you can end up with a very large tables with a lot of empty fields. Okay, next slide. So the second approach is what I typically use because, and I'm sorry, the first approach is ideal for those single submitter types of studies. And for very straightforward types of studies. This second approach I developed based on readmissions, hospital readmissions, in this article that I've linked. But it takes care of the fact that there's overlapping segments of enrollment, and it calculates gaps of coverage. Let's go to the next slide. Okay, so what you would see or expect to see is that, for instance, the first 2 records belong to a single individual. And you can see that their first enrollment segment was 28 days long. And their second enrollment segment was 163 days long. But there was a gap between the first and second enrollment segment. And it gives you the actual length of time of that gap. And if you have multiple gaps, you'll see those on the different sequences. Of course, a disadvantage to this one is it is pretty complicated code. But there's, like I said, there's the article out there. There's several other articles that also look at readmissions and the overlapping segments. Yeah, I find this necessary for studies with a lot of different payers, or when you're looking at individuals and you want to look at their healthcare coverage over long periods of time. not necessarily when they have to have the same payer. Okay, do we want to do any questions now, or do we want to wait? Do we have time for questions?
We have time for a couple of questions if anybody would like to ask one. While folks think about what they might want to ask, I will say that I concur. Nicole, continuous enrollment is never as straightforward as it may seem. If you're lucky to deal with some submitters that are pretty clean, that's great, but there can always be more. And I also thought, as you move through this, that a potential topic for a future data users group is perhaps how to utilize the QHP data in the Arkansas APCD. So I will put that as a note for next time.
Yes.
And for the audience, these slides will be available on the website, and if possible, we'll put the link in the survey email. But if not, we can send an email to everybody who's participating, so that they can have these slides. Let's go. I don't see any questions yet, so let's go to the next slide. And I'm going to introduce our next topic, the Arkansas COVID-19 analytics. Mike Motley will be our speaker for this particular point. This will illustrate a lot of the work that ACHI is doing in the space, and perhaps can give you some ideas for future use. Mike?
Yes, hello everyone. I want to make sure you can hear me. Looks like
Yep.
you can, based on Kinley nodding her head. Okay. Yes, so I'll just jump right in. I'll go kind of quick because you guys are going to have these slides provided to you, but I want to give you a sense of what we're working on with some of the data. Obviously, a lot of our efforts have been around COVID-19 impact analyses. We, on a weekly basis, update our community and school district level dashboard. We do this in partnership with the Arkansas Department of Health. As you can see here, this is kind of one look on our, if you go to our landing page, which is down there at the bottom, you can see the link. We do trends of new cases, or new known infections rather, per 10,000 among populations that reside within school district boundaries, and then within community boundaries, which we are defining as a zip code or group of zip codes. And then we do just zip code level to go down to the most granular. But as you can see here, if you look at Alma, for instance, on the top row there, we've got a color-coded scale. In the most recent update, they were at 36 new known infections per 10,000 residents, putting them in the orange category there. We do have mapping capabilities, of course, that go along. And let me actually make a point that these are normalized per 10,000 residents. You'll see some of the dots there don't have a number in them. We have to suppress any rates that would be coming from a numerator of less than 5. And that's something we've landed on with consultation with the Department of Health to protect from small numbers or any kind of identification issues. We do update this every Thursday. We should have an update coming tomorrow. And on the next slide, you'll actually see where we mapped the different geographic levels that we report at. This is the most recent update of our school district level map. Unfortunately, in the last update, there were about 42 school districts that were in what we call the red zone. There were 5 or 6 that had over 100 new known infections per 10,000. But you can certainly see in the northeast quadrant up there, moving in the wrong direction there as of our last update. So we are tracking this closely. On the next slide, we also do heat maps on a weekly basis. The underlying shading is the number of tests, and the shaded areas on top are the new known infections. And obviously Central Arkansas, Northeast, Northwest, and even down around Texarkana, picking up some more infections there as well. So this is another one of the things that we do in this space. On the next slide, we have broken down hospitalizations and deaths by age group. You can see the 45 to 64-year-old group actually accounts for the most hospitalizations, while the 75 and above age group accounts for the most deaths. Unfortunately, we do see more, or a couple of deaths coming on in even the younger groups there. This is something we update again weekly, and we share this on our site. There's a couple of more things that are descriptive statistics on our site. Time to next 100 deaths and new hospitalizations, and a couple of other graphics that are just kind of a different look than some of the things, and different numbers than some of the things that the Department of Health are releasing. So we continue to work with them on that. On the next slide, we are also supporting in the COVID-19 impact analysis space, the state and public school employees plans, or the employee benefits division. We are able to, in support of them, not only use the data we receive from the Department of Health, which is collected via REDCap, which stands for Research Electronic Data Capture, which is their chosen secure web application for contact tracing and other purposes. We receive data that's collected through that system, and we are also able to look at claims, actual health insurance claims data for state and public school employees. Excuse me. So when looking at data from March 17th through September 28th, we were able to establish that just over 47,000 members have ever been tested for COVID. The total with a positive test was 4,082 at that time, pretty evenly split between the state employee and public school employee populations. For context, this plan overall population is about 160,000. We're also now picking up antigen tests or verbal positive probable infections, almost 300 of those among plan members. We're also able to look in claims at tests that were paid for by the plan. The plan administrators are interested in that. Obviously, their members can go and get a test and either get a free test or pay for it themselves out of pocket. The plan is consistently paying for about a third of the tests that its members are receiving, in that ballpark. So on the next slide, you'll see more of the analyses we're doing here. Total members ever hospitalized, 253, again, pretty evenly split across the state and public school employees. Going along the path of more severe outcomes, 87 members have been admitted to the ICU. That's just over 2% of the positive cases. And then members on a ventilator, 38 all time, that's just under 1% of the positive cases. Unfortunately, there have been 34 deaths among members of the plan. On the next slide, we've done a little bit more of a breakdown of the type of testing volume. This is from claims data. So it's about a third of total tests, but still you get a good sense of the kinds of tests. Molecular PCR is the majority. I think we'll see more of those in July when the claims experience becomes a little more mature. We're actually working on a very rapid cycle flow here with the Employee Benefits Division to use their data as soon as we can get it directly from them. Of course, this plan is also within the All Payer Claims database. So it is going to be part of that as well. You can also see antibody tests, claims for COVID tests, but they're not specified which type of test it is, in the kind of teal color. And then just in June and July, starting to see some antigen tests come along in the claims. And we know there's going to be a lot more of those in August and September and so forth. On the next slide, we've also looked at telemedicine utilization. Obviously, it's a whole new world of telemedicine utilization in the COVID era. As you can see, the huge spike there in April. Among the plan's 160,000 members, we had under 200 telemedicine visits a month was kind of the norm pre-COVID. And then you see picking up in March, April, and then coming back down somewhat. Again, there's going to be additional claims that come on as they're filed that will retro update these, but you get a sense of what that initial spike was and then kind of where we're coming back to a new normal in terms of telemedicine utilization. We've looked at this a couple different ways. On the next slide, you'll see from April through July 24th. Again, this is state and public school employees. We looked at among all of their primary care and mental health visits, what proportion were done via telemedicine by county. And you kind of get a sense there from just under 10% to around 25% is the spread there. With the central part of the state, Northwest Arkansas, and some other areas having the most, proportionally the most of those types of visits done by telemedicine. So there's a couple things we're considering there, you know, looking at rurality of counties compared to proportion of telemedicine or uptick in telemedicine utilization. So we will definitely continue to track this, and we'll ultimately be able to look at this for the entire state populations that are captured in the APCD. So we plan on doing that. I think that is all of my slides. There might be one more, but if not, I will stand for any questions and go back to Kinley.
All right. Hey, Michael, would you go back a slide to the map? Okay. Mike Motley, we have a Michael and a Mike. Do these represent where the provider location or the member location?
Great question. This is where the members live. This is based on residents.
That's interesting. I would have thought for the, that's very interesting. I would have thought there would be more rural activity, but interesting. And and also the EBD work, the Employee Benefits Division work, did come from all payer claims database data. And I believe you said that. And while we haven't expanded that to other carriers or plans, theoretically, the foundation is laid for COVID analytics based on the EBD work you've done. Would you say that's true?
Yes, that's a good point. And it's really kind of an early indicator just with looking at that plan of what's going on in the commercial sector for the fully insured. The EBD plan is the state's biggest self-funded plan. And it is administered through the third-party administrator, Blue Cross Blue Shield or Health Advantage. So it's really a subset of that experience in the state. So it's going to be really interesting to see a broader statewide look at this.
Thank you. Okay, Michael, now you can forward. Okay, so the last part of the session today, in the next 14 minutes, I want to talk to you about the latest APCD release, the new data that we have. Good, interesting information, I think, if you are planning on making another data purchase, or for those of you who have subscriptions, what the latest data may contain. So, Michael, let's move forward. The latest infographic is available. In the interest of time, I will let you click on that when you get the deck. But the second bullet here is, to us, is a valuable piece of information when communicating about the data that we're producing. So we update our database quarterly, and we have a naming convention now. So if you look in the example column of this table, you can see 20A, 20B, C, and D. Well, 20 is the year, and then A, B, C, and D represent the quarter. You can see how we put it together there. We will fulfill data off of the B and the D builds that we do, unless it's a very special request. The two others, the A and the C build, allow us to apply additional fixes or cleanup or anything in the middle that will enhance the data for data submission or data release. But I wanted you to be aware that you might hear us talk about the data that we pull for you using this nomenclature, the A, B, C, and D. Let's go to the next slide. So the data that we have available right now, this very instant, is between January and December, 13 through 19. So that's 7 years of data, right? 7 years of data that's available to you. We have also started to produce release notes that include coverage dates, and this time it's the naming convention, and then source specific things you should be aware of. I'm going to see if I can click on, Michael, can you click on that and that link and go out there? If that doesn't work, then we'll give it one try. There we go. So when you click, you'll see this page, release notes, and then you can click on this link. Thank you. And this is information you will need to know about the build. This is the 20B build from which your data will come, and we'll communicate that information for you as we do the data request process. So there are some things that you will need to know. This is in addition to the tips and issues about some of the submitters that we have. So we're not going to go through this, but I want you to be aware that this is a tool for you as you look at your data. As Nicole described, this data can be very complicated, not just within the carriers themselves, but how they give us data. And we want you to be equipped to use it. So let's go back, if you can, if you don't mind. Thank you. Let's go to the next slide. All right, with every release, we will update where possible, as needed, the attributes deck and the universe count. So let's talk about the attributes deck. I'm not going to ask you to go there, Mike. I'll just talk about it. On our website, at this link, there's a deck called the data attributes. And what it does is it lays out how the data relates to each other at a high level, how claims relate to member data, how enrollment data may or may not have claims associated, and how to find individuals, members between and within carriers. It also talks about the APCD unique ID, or the hash ID that we call it, that is our proxy for the PII, which we do not get yet. So you'll recall it's the concatenated last name and date of birth processed through a custom hash routine. So if I have a plan on Blue Cross and a plan on QualChoice and a plan on Delta Dental, I'll have the same hash ID, and you can group them that way. Again, we talked about hash IDs a couple of data user groups ago. Those links are on the website. Anyway, I point this out because I get questions a lot about why, when you group on hash ID, you get multiple genders. And so I always point the data users to the attributes deck, and then also explain that you concatenate your hash ID with your gender, and there's some other tips that you can use. Always look at your attributes deck. It's very, very helpful. And you can always call us too, but it's very helpful. So the universe counts, let's click on that for just a second, Michael. That should go straight, if it will. Let's go down to the page, and you can see it's the number 5, and that will open an Excel spreadsheet, and you can click it. It's going to look like it's mad at you. Just click yes. It's okay. Excuse me. So this information used to come in a PowerPoint deck, and let's go over to the first tab. And that was fine and good, but you can't add data in a PowerPoint table. So we spread it all out in this spreadsheet that you can download and manipulate as you want. The second tab is the report tab directory. That's all the tabs that are in here. And let's go to the third tab, coverage by SE. So this is an important thing for you to consider and use too, because we have a lot of submitters. You can see here, lots and lots. And some of them haven't submitted the 2013 through 2019 data that this database includes, because some submitters are purchased by others, some stop being qualified to submit and don't anymore. So this tab right here can help you understand the data that you receive. If you look at, look at row 5, United Healthcare of River Valley, you think, well, I don't have any claims later than 2017. Why is that? Well, this can help you understand why. Okay, So let's close out of that and go back. I do encourage you, those are good tools to use. And those bullets define or describe what's in the universe count. So let's go to, oh, before we go, I didn't show you, but there's a new report at the end of the universe counts that shows you ICD-9 to ICD-10 coverage. We've gotten a couple of questions about, you know, when it theoretically, it was supposed to transform from 9 to 10, ICD-9 to 10 in October of 2015. Well, no. That wasn't a clean cut, and many carriers sort of trickled the ICD-9 throughout the years until now. And so that report will show you, if you look at a carrier, if you need to look up ICD codes, how many are 9 and how many are 10. It's kind of helpful. All right, next slide. We have 6 minutes. Okay. Always look at your tip sheet. And the data dictionaries are there to be helpful too. Some data requesters, users still have the PDF doc for the data dictionary, and that's great, but those don't get updated anymore. The online versions do. Some highlights from the tip sheets are, there's some tips about using the pharmacy claims from those 2 carriers, past data. There's new service provider information in the EBD medical claims. And for those of you who have a subscription, I think the Arkansas Bioscience Institute is really the only user that has this, that might have this issue. The very first cut of that subscription data was 2018, and there are 2 fields in the cancer data that have truncated fields. Values. That's all been resolved, but if you're using that really old cancer data, then you might see that problem. But look in the tip sheet, it's in there. Next slide. Again, don't forget to use your tip sheet. Next slide. Okay, well, that was fast. We have 5 minutes left. Does anybody have any questions? If so, enter it in the group chat. These slides will be made available to everyone. They'll be online. And you will receive an email for a survey, and please fill out the survey, and please, we encourage you to note in the survey any topics you would like for us to cover, because we respond to you. All the things that we talk about are to support questions that we've received from our data users. So we want to make the data easier, and we want a lot of knowledgeable users. So I don't see it. Michael, do you see any questions in the chat? I do not.
No, I don't.
No?
Nope.
Nope. All right. All right. As always, reach out to us. Here's our technical support link for anything, requests, data use, pricing, technical support. We are there. When you submit a request here, it goes immediately to my email and to the emails of the rest of our team, and we can respond to you very quickly. Well, that said, and no questions, I thank you everybody for attending today. We do have some special guests on. The president of the National Association of Health Data Organizations, Norm Thurston, is on today. Thank you, Norm, for joining us. Arkansas is a member of NADO and the APCD Council. And there's some future data users on too. I've talked to you on the phone, and I hope that your journey to a data request is shortened now based on this information. That said, I'm going to let everyone go. Look for your survey. Thank you.
Thanks, Kenley.
Thanks.
You're welcome.